This is an attitudinal problem. This has nothing to do with the resource constraint, as people do realize. Because the medicines should not be going to mean, the medicines should be going to serve that child of that poor man who has sold his assets in order to bring the child to Civil Hospital, Karachi. And that is a tragedy which is taking place every day in every big city of Pakistan. And this is nothing to do with either public policy or the resource constraint. An income tax officer, if he gives a call, 6 specialists will run to his office and to his home. And then on the other hand, we have bulk of the population which are poor, which do not have access to the basic health care system in this country. And this cannot go on. The third dimension which he points out is that the first level care facilities in this country are where we should concentrate. Because today there is no screening and referral system. We have built the basic health units and the rural health centers, and then we have the Tehsil headquarter hospitals, then we have the district headquarter hospitals, and then you have the teaching hospitals or the large hospitals. But what is the status of these first level care facilities? You do not have medical doctors there, you do not have medicines, you do not have even the paramedics in those places, and particularly in the backward districts. So I have recommended in my present capacity as chairman of the Pay and Pension Commission that we will take out education, health, police, and judiciary, the 4 subjects with which every citizen comes in contact with the public officials, out of this pay scales which are done a lot of damage to the backward areas. If in Musa Khel we can get a doctor at 25,000 rupees, we better pay him 25,000 rupees. And if in Quetta we can get him for 15,000 rupees, we should pay him 15,000 rupees. Otherwise, this gap between the backward areas and the developed areas of the country will completely engulf us and widen, and you will have 2 classes of citizens. Those who are better off living in the urban areas, metropolitan areas, and the big cities, and the remaining population have no access to education, health, drinking water. And unless you come to grips with these kind of fundamental reforms, which are of the future nature, not the past nature, I do not think some of the reforms which have been advocated in her book would ever be implemented. So I'm once again very grateful to her for a very painstaking problem, and I conclude by quoting from Dean Julio Frank, who wrote in the preface that the most important impediment to reform in Pakistan is the country's public sector institutional culture, which is focused on short-term goals as opposed to evidence-based, long-term, enduring actions with potential to bring sustainable change. This is what Sani Nishtar's basic message is. We are a country full of rhetoric and emotions, but we don't face the facts, we don't collect the data, we don't do the analysis, we don't look at the evidence, and she is one of the few scholars which has done all of that. Thank you very much.
Thank you, sir. Our next speaker is currently the Vice Chancellor of the Beacon House National University in Lahore. He is the former Federal Minister for Finance and Foreign Affairs. He also remained the Secretary General of the Pakistan Muslim League N. Mr. Sardar Aziz. Sir.
Auzu billahi minesh-shaytanir-rajim. Bismillahir-rahmanir-rahim. Dr. Ishrat Hussain, Ijaz Rahim, Mr. Billy, Mina Sayyid, Excellencies, ladies and gentlemen. I am grateful to the Oxford University Press for inviting me to participate in this book launch because it represents an important milestone in Sania's illustrious career. Having closely observed most of the milestones in her life over the past 2 decades, it is of special significance for me to see this manifestation of her lifelong commitment to help humanity through better health care and better health. As most of you are aware, the first vital step for any reform in any sector requires more detailed knowledge of the issues, constraints and possibilities of that sector. Sania has painstakingly collected data on different dimensions of the public and private health systems, from governance to service delivery, from medicines to human resources, and presented it in a very concise volume. Anyone connected directly or indirectly with the health sector would be able to see very clearly why the particular pipe with which he or she is concerned is blocked and what can be done to unblock it. So that itself is a great service because it gives a chance to every participant in the system to be able to do something about it. In my view, the most important chapter of the book, which all policy makers must carefully read, is chapter 3 on health governance. Governance reform, Sania says, is only partly technocratic. It's largely a political process, both in terms of setting policy direction as well as reforming the public management process. Politicians and power holders engage in governance reforms in response to their own political interest and see them as a way of winning support, building or breaking coalitions and reshaping the dynamics of political influence. Therefore, any meaningful governance reform must be based on a sophisticated understanding of these factors. So, if you really read these words carefully, you will know why reforms are so difficult to take place and implement in Pakistan. After explaining different domains of health governance, she lays particular stress on implementation and oversight. Core competency and capacity are necessary prerequisites for public management. This can be ensured through merit-based recruitment. This prerequisite, as we are all painfully aware, is not generally met in Pakistan. So if we ask one most important flaw in our governance, it is the absence of a merit-based system, whether it's recruitment, whether it's promotion, whether it's transfer. Similarly, there is insufficient understanding of human resource planning or the importance of an incentive structure for professional cadre. In fact, the system does not reward high performance. On the contrary, it discourages it. Rules and regulation also over-centralize decision-making. The 2001 devolution plan has created another set of problems and tough battles over procurement authority and contracting decisions. Sania's solution is two-pronged: appropriate remuneration coupled with accountability, and leveraging of technology as a deterrent against current exploitation of manual record keeping. For a reason you readily understand, I read with particular interest chapter 4 on health financing. As Sania points out, changes in the mode of health financing can be used as entry points for reforming the health system as a whole. And she identifies a number of financing issues which are particularly critical. Total expenditure on health, she points out, in 2005-06 was 2.9% of GDP, but the public sector spending was only 40% of that. That is 1.16. This translates into $13.24 per capita per annum, or $22, compared to WHO's recommended figure of $34, which we should have. If we have to reach that, our public expenditure has to go from 1.1 to at least 2% of GDP. But within this modest expenditure of 1.16 of GDP in the public sector, a very sizable portion of that is 4% of GDP, 0.4% of GDP, is spent by government agencies, autonomous bodies, including the armed forces, on providing health care to their own employees and their dependents. So these figures do not come under health allocation. They are shown in the budgets of their respective governments. That is why this becomes, even the public money that is spent is inequitably distributed between those that will go to the government employees or armed forces of their health care, and that to the others. That's why the allocation for ordinary citizens is only 0.7% of GDP compared to the WHO's recommendation of 2%, and that is why the figure that you just heard, that 70% of the population does not have full health coverage in the country, and that is one of the key factors. Obviously, the private sector, she is pointing out this interesting fact. Private sector costs on health are larger than those in the public revenue, which is a very great tragedy because only public sector can guarantee the health of the poor. These private sector costs are not only the health bills of the rich and expensive hospitals, but it includes the expenditure which low-income citizens are forced to spend on health care because no public facilities are available to them. Some of you may have seen 4 years ago a UNDP report that on average, the average breadwinner in rural areas is sick for 66 days on the average in a year. And since he does not have access to public facilities, he has to sell his wife's ornaments, the only cattle, livestock they must have, and therefore he is pushed into perpetual poverty. So that's where the health expenditure in the private sector accounts for. Sania also points out the need for an overarching mechanism to ensure that federal, provincial and district allocations jointly contribute to the attainment of nationally agreed objectives in the health sector in line with stated priorities. Under the present system, the bulk of the health sector expenditures are at the provincial level and provinces receive financial resources under the NFC formula. Any fluctuations in the federal revenues can therefore lead to disproportionate reduction in provincial health allocations, and therefore you can see that if the federal government, the national health policy, may decide X amount to be allocated to health, if the provinces don't have the money and their priorities are different, it will not happen. And under the new plan, which is under discussion in the Parliamentary Committee on the Constitutional Reform, health is going to be a provincial subject. Now, Dr. Rahim has rightly pointed out that we are not talking of federal, we are talking of national. But we are going to see a phase when there will be a demand to abolish the health ministry in the central education ministries. If that happens, would we have 4 health policies? And how do we ensure the capacity building and the governance in the 4 provinces? This is going to be a very major challenge if the recommendation in this report have to be observed. The task of then putting the four health policies under a national umbrella and finding enough motivation either through money or through some better social sector planning to persuade the provinces to follow that policy will require a kind of qualitative and institutional change in the federal structure which I don't see at the moment. So it's a good vision to keep in mind, but how do we achieve it? We are going to have, in my unfortunate assessment, a deterioration in health governance in the coming years as it is provincialized because the provincial capacity at the moment is much weaker than even at the federal level. This book, Choke Pipes, on page 11 presents a very useful list of health initiatives, goals and strategies culminating in the Millennium Development Goal which was established by the United Nations at the 2000 UN Summit. It gives you a chronology of different goals. But the unfortunate part is that the 2006 review points out that at this midpoint, Pakistan is not on track to achieve the MDGs by 2015. There are very specific goals which were laid down and we are not on track in receiving them. And even more seriously, the global concerns in favor of a transformation from focus on different diseases to health system as a whole has to be fully integrated into health planning and health implementation in Pakistan. The changing the pipe, which is Azad Rahim talked about, refers to this transformation. So it's not only that in terms of the present indicators we are not on track, the kind of change that is required, qualitative change that is required to achieve those objectives is not there. So Sania's book therefore provides a very valuable handbook in moving towards the MDG and how to achieve them and how to achieve the transformation towards the whole health system approach.